Hi, everyone. Starting on the dot. Thank you for joining us today for our webinar on the landscape of digital health reimbursement policies in Japan. So before we get started with the presentation and the discussion, I just wanted to take you through the agenda for today's webinar. So I will just be starting by giving you a brief introduction of APACMed and our Digital Health Committee. Then we will be moving to Sekiguchi-san, who will give you an introduction of the webinar and this topic today. Then moving to a presentation and panel discussion with Dr. Morimoto, Tomohiro Watanuki from AMDD and Medtronic, Sekiguchi-san again, and Makoto Tamura from closing the webinars with some remarks from Danny Wisberg from Baxter. So just before I move to the introduction from APACMed, I just wanted to mention that please, if you have any questions during the presentation, you can use the chat function in the parameter bar that you have at the bottom or at the top of your screen. So use the chat function, use the Q&A function. We will answer your questions. Thank you to all of you that send your questions as well before this webinar when you registered. And if we don't answer your question during the webinar, we will follow up by email afterwards. You will also have a interpretation of the second part of the webinar. So the second part of the webinar will be in Japanese, and we will have a translation in English as well. So everything will be again in the setup bar. So just briefly about APACMed, we are the only regional trade association that represents medical device manufacturers in the region. We count 230 members companies. They range from startups and SMEs to bigger multinational companies. And we work in different work streams. So this webinar today is presented by the Digital Health Committee in partnership with AMDD. So for our Digital Health Committee, we count 250 individual members coming across 75 companies. And we work in four main different areas on digital health. So digital health regulation, cybersecurity, interoperability, and on this webinar today, digital health reimbursement. So I won't take much more of your time. I will now hand over to Sekiguchi-san for his introduction on the topic. Thank you again for joining us.
Thank you, Cindy. My name is Jun Sekiguchi. I'm a chairman of the Japan COE of Digital Health Committee of APACMed, and also a member of AMDD. And I belong to a company, Baxter Japan. And today I would like to touch on the situation of the digital health reimbursement in Japan. So next page, please. Here on this page, I would like to mention about the changes of the regulation for digital health. In the past, the regulation for the medical device, including software, was totally done, including software and hardware as one product. So software is supposed to be specific to hardware. And if there is any change on the software, or if there is any change in the hardware, we needed to do some change of the application or modification as a whole. But in new regulation, the hardware and the software are separated. So whenever we have some change in the hardware itself can be modified. And more often, maybe software will be upgraded. And in this case, only software can be modified or made a change in application. And in this case, these software, since these are separated, we call it the software as medical device. And we shorten it to like SAMD, SAMD. And under this situation, whenever we have a hardware change or even the general device like an iPhone, where it has the many upgrades on the hardware and also OS. But if there is no need to change the software, we don't need to change. So there are more flexibility on application of the software. So these are the thinking of the new regulation. Next page, please. And according to the Pharmaceutical and Medical Device Act, not every medical device software, which is SAMD, will be considered as or categorized as the medical device, which means that the whether it will be a medical device or not will be determined by the degree of risk and influence on therapy decision. And in this case, those software which has a higher degree of risk, and also when it has the big influence on the therapy, would be regulated as the medical device, as the software. So in this concept, there will be some classification as in the usual medical device. And the next page, please. Here on this chart, it shows the current classification of the medical device and how it will be applied to the medical software like SAMD. And in this classification of medical device is defined by JMDN, and it's classified as class 1, class 2, class 3, and class 4 according to the risk of the influence to the human body. And many of the SAMD will be classified as class 2 or 3, whereas mobile patient applications are outside the definition of the medical device. And in the case of the class 1, this is the area where there is a difference between a usual medical device and medical software. And in the case of the medical software class 1, risk is considered to be outside the regulation. So this will not be considered as the regulated medical software. And in this categorization, it relates to the health insurance coverage. And in the class 2, class 3, class 4, medical device software will be covered by the health insurance coverage. However, the class 1 risk devices are not covered by the health insurance, and this will be the something to be need consideration. Next page, please. And as for the reimbursement, the MHLW announced the direction at the end of last year at a conference called the Central Social Insurance Medical Council, which we call it the Chuikyo. And according to this criteria, reimbursement evaluation of medical device software, which is SAMD, will be done in one of the followings. One is the generally included in overall technical fee, or added on to specific technical fee, or included in specific technical fee, or separately reimbursed as specially treated medical materials, what we call STM. And among these four, number 2 and the number 4 is considered to have the separate pricing for the product. However, number 1 and the number 3 is inclusion into the existing technical fee, which means that not always these cases will accompany with any change of the technical fee. So if the technical fee doesn't change in case 1 and 3, it means that there is no obvious reimbursement evaluation onto the current technical fee system. So more and more, we have the example of the SAMD. We would need to make it in specific technical fee addition, or if possible, separate reimbursement as the STM will be required. And another thing that the MHLW has announced was the therapy supporting software that will reduce healthcare professional workload may be evaluated through medical institution standard. We call it shisetsu kijun in Japanese, which means that the criteria of the hospital or clinics. So this way of evaluation is not the specific change on the reimbursement price itself, and change of the institution standard, which makes it easier for the application to be used in the hospital. However, as for the price perspective, there will not be any change in the pricing. So that would be another direction that we need to pay attention to. And next page, please. And according to these directions, on this chart, I have demonstrated how the current reimbursement will be done according to the category, and how SAMD will be applied. And then in the current category, there are drugs, medical device, and hospitalization medical, these physician's fee portion. And these will be reflected into the reimbursement type of the by brand reimbursement for drugs. And for the medical device, it will be reimbursed by separate codings according to the functional category or by the technical fee. And in the case of the SAMD, in many cases, the medical software reimbursement or evaluation is made through the technical fee. And according to the direction by the MHLW last year, there is a possibility that the SAMD will be reimbursed as the STM, like current functional category evaluation. So the difference between STM and the technical fees, for technical fee, it's a mix of the product itself and also several costs accompanied to the therapy itself, whereas the STM is the evaluation only for the medical device. And next page, please. Can you go to the next page? Yeah. And here is that one example of the new reimbursement approval in the 2022 revision, which is the peritoneal dialysis remote monitoring. And the evaluation of this device, SAMD was supported by local and global data, and realized through discussion at Chuikyo Council. And in as the dialysis therapy is the long-term therapy continuing for several years, this type of evaluation was suitable for the technical fee evaluation. So the price of this reimbursement is 1,150 yen per month per patient. So it may not be a big amount, but as the therapy continues for a long term, it will be beneficial for the as the reimbursement. And going forward, there should be a lot of discussion how the software medical device should be reimbursed. And I think this is one example which could be done with the support from a medical association, and lots of support from data. Hope that this kind of the reimbursement will be realized in the future. And I think this will be the detail will be explained at the next presentation from Dr. Morimoto. Okay, Dr. Morimoto, can you go through your part?
Okay, thank you. Thank you for listening. I'm Dr. Morimoto, and I'm a clinician at Keio University Hospital, and I'm very specialized in nephrology and dialysis therapy. Here, following Mr. Sekiguchi's presentation, here I would like to talk about the real world of peritoneal dialysis therapy, PD therapy, and the PD-related digital health service, and the result of a clinical trial about the efficacy of the Baxter's digital health service named ShareSource. So let us begin. Next page, please. So kidney dysfunction is one of the most popular life-threatening chronic diseases in the world. Various diseases such as diabetes, obesity, hypertension, some kind of malignant tumors, and genetic diseases impair renal function. Renal replacement therapy is essential for the patients with end-stage renal disease, ESRD, presenting less than 15% of healthy kidney function. Renal replacement therapy comprises renal transplant and chronic dialysis therapy. Approximately 300,000 patients in Japan and 1.5 million patients in the world are receiving chronic dialysis therapy. Dialysis therapy consists of hemodialysis, HD, and peritoneal dialysis, PD. PD is only 3% in Japan and about 15% in the world. Here are the practical features of PD. PD is home-oriented, needs much less frequent hospital visit. PD is mild, light burden, and so friendly with the patients with much morbidity. And PD needs less medical expenses and infrastructure like clean water supply and electricity. And so PD is regarded as a relatively cheaper dialysis therapy in most countries other than Japan. Next slide, please. These pictures show real situations of performing PD at home. PD patients have a special catheter endured in the abdomen in the peritoneal cavity. Patient and or his or family and or home medical care staff connect the tubes to the specific dialysis solution in the set procedure and fill the cavity with the solution to remove life-threatening uremic toxins and excess water accumulated because of renal failure. In many cases, the procedure is repeated 2 to 5 times a day, continuing every day for several years. Next slide, please. So this schema is presenting legacy clinical data management in PD. PD is home-oriented, and medical staff must collect the results of the therapy. Patients write their PD records in notebooks, bring them to the hospital. Medical staff assess the data for clinical management. The data are shared with by analog way with home medical care staff in some cases. Next slide, please. So this schema is presenting clinical data management in PD with ShareSource, the new service. ShareSource is a connectivity platform for automated PD, enables cloud data sharing. With ShareSource, the data are shared interactively, data collection and prescription. So medical staffs, both in-hospital staff and home medical care staff, can share the data very easily. Next slide, please. And we conducted a crossover randomized controlled trial to evaluate the effect of ShareSource. The study includes 15 patients conducted for 24 weeks. This study was the first RCT of ShareSource in Japan and Asia. As a result, the use of ShareSource significantly reduced average medical consultation time and increased the times of prescription change. The increase of the change would bring optimization of PD prescription. And various healthcare resource consumption tend to be reduced by ShareSource. Next slide, please. In terms of patient satisfaction and quality of life, use of ShareSource improves them. Our study and its result had been published. Thank you. Next slide, please. So this is the final slide of my presentation. ShareSource is the first insurance-covered digital health service for dialysis patients in Japan. Compared with the already covered artificial cardiac pacemakers, CPAP, and HOT, the new coverage is for much patients. The pros of the ShareSource coverage: first, it would accelerate development and clinical application of digital health and remote monitoring devices and services. Second, it would be a turning point of insurance coverage policies in Japan, because this is the first software, this is the first cloud service, and this is the smaller number of patients than the already covered medical devices. So on the other hand, cons of the coverage. The first, effect of digital health on clinically important outcomes is still unclear. So larger clinical studies should be conducted. Second, the increasing amount of data would be burdened on medical staffs. Data analyzing service and or the additional coverage of additional burden will be welcomed. I'm sorry, I don't know about the probability of insurance coverage. Thank you for listening. This is the end of my presentation. Thank you.
Okay, so let's get started panel discussion. From now on, we are going to talk about only Japanese, and the interpreter will be provided translations. ここからは日本語でやらせていただきます。私は AMDD のメディカルテクノロジーポリシーインスティテュートの田村と申します。ファシリテーターをさせていただきます。通訳どうぞ。
So from here, we will talk in Japanese. I am Tamura. I am from MTPI, AMDD. Thank you very much. I will host this panel discussion.
はい、それでは早速始めたいと思いますが、今お話をいただいた腹膜透析の遠隔モニタリングに、保険が診療報酬がついたのは日本では4つ目です。
So let us start the panel discussion. So this is the fourth remote monitoring addition to the insurance coverage, this PD, peritoneal dialysis remote patient monitoring addition.
これまで3つは、ペースメーカーと、それから CPAP、それと在宅酸素の3つにその保険がついてましたが、この4つ目でついたものは何か前のものに比べて特徴がありますでしょうか。森本先生と綿貫さんにお伺いしたいと思います。
So the first three were pacemakers, CPAP, and HOT. home oxygen therapy. This fourth edition, is there anything unique about this time around? Dr. Morimoto, Dr. Watanuki, please.
ありがとうございます。森本です。先ほどプレゼンテーションご清聴ありがとうございました。私が考える今回のシェアソースが保険でカバーされることになったことの今までと比べての特徴としては、一つはそのデバイスではなくてサービスについたっていうところがやっぱり大きいかなというふうに思います。これは関口さんからも指摘のある通りですけれども。
Thank you. This is Morimoto speaking, and thank you very much for your attention to my presentation earlier. So one feature of this coverage of share source is that it covers not the device, but the service, as also mentioned by Sekiguchi-san.
あともう一つはですね、患者さんの数が今までの、例えばペースメーカーとか CPAP とか HOT と比べてすごく少ないんですよね。で、これもだから、国がどういうことを考えてこうシェアソースのカバーをしたのかっていうところを考えるので非常に興味深いポイントかと思います。
Another point is the number of patients. This share source, fewer patients, the PD has fewer patients than the pacemaker, CPAP, and HOT. And so it is very interesting on what the government thinks, what their thinking is behind this coverage of share source.
ありがとうございました。森本先生のその確かに、デバイスではなくてサービスっていうところですけど、例えば今、遠隔で ICU なんかをやってますが、そういうサービスなんかにも今後保険がつく可能性があるというふうにお考えでしょうか。
Thank you very much, Dr. Morimoto. So you mentioned it's not for device, it's for the service. Do you think it's possible that other services will also be covered for the remote monitoring going forward for other services as well?
おっしゃる通りにその可能性が非常に高くなっていると思います。で、考えられるのは、実際そういうリモートサービス、デバイスではなくサービスの臨床的な意義っていうものを国がしっかり認知している可能性。で、もう一つは、こういったものに関して臨床的な価値は、特にその長期の臨床管理における価値っていうのはまだはっきりしない部分が多いと思うんですけど、そういうものに対する明確なエビデンスを出していくために、あえてここで一気に承認し始めたというふうに考えることもできるかと思います。
Yes, the possibility is rising, I think. And this time it's remote service, not device, but service. This may imply that the government is recognizing the clinical significance of the remote service. And another point is this clinical value. The long-term clinical value is not clear yet. And therefore, they may be starting to approve these services now to clarify have clear evidence on these clinical values.
ありがとうございました。綿貫さん、いかがでしょうか。
Thank you. Watanuki-san, please.
はい、日本メドトロニック、綿貫と申します。同時に AMDD 保険委員会の委員長をさせていただいております。よろしくお願いします。
Thank you. This is Watanuki. I'm from Medtronic, and I'm also the AMDD STM committee chair. Thank you.
はい、今回のこの4つのペースメーカー、CPAP、酸素、それから、この透析の違いというものを保険の観点から少し見てみたいと思います。
So let me talk about the differences in the the pacemaker, CPAP, HOT, and PD from the insurance point of view.
まず点数に関してですけれども、ペースメーカーが3000円、もしくは4000円ぐらいの比較的他のものと比べて高いということがあります。
First of all, in terms of points, pacemaker is relatively higher than others, 3,000 or 4,000 points.
そしてペースメーカーのその算定できる期間というのが最長1年間積算できるのに対して、それ以外のものが最大2ヶ月というところで期間が異なっているかと思います。
And another difference is the duration. A pacemaker calculation period is maximum 1 year, but others are maximum 2 months. So duration is different.
そういう観点から申し上げますと、この最初のペースメーカーというのは、政府にとって初めてのモニタリングの評価ということで、多少試行錯誤のところはあったのかなと思う一方で、それ以外のものは比較的同じ条件ですので、評価の方法が定まってきたのかなというふうに感じております。
So from this point of view, I can see that the pacemaker was the first monitoring evaluation for the government. And so I think they were still in a trial and error phase, as opposed to others. In contrast, the others, the evaluation, the condition has been stabilized, fixed to the same condition, I think.
ですので、今後のモニタリングということに関しては、この例が先行事例という形で、厚生労働省としては同じような評価をしてくるのではないかというふうに感じているところになります。以上です。
So regarding the monitoring going forward, this example is the first example, and we think MHLW will pursue same evaluation going forward. Thank you. That's all for me.
渡辺さん、ありがとうございました。会場からとかフロアから質問が来ていて、その今のシェアソースの件に関してです。今回、そのクリニカルベネフィットが、先ほど森本先生がクリニカルベネフィットはまだあまりクリアでないというお話がありましたが、にもかかわらず、その加算がついた、ニューテクニカルフィーがついたということについて、やや驚いている、あるいはどう考えればいいかというようなご質問です。で、それとも関連するんですが、今日エビデンスとしては、リソースコンサンプションの話と、それからQOL の話とも2つありましたけども、今回、厚生労働省がそのテクニカルフィーを新たにつけたのは、これ両方見ているのか、どっちに重きがあったのか、それも含めて会場のご質問に、どうしてあまり明確でないのに、この加算がついたのか、ニューテクニカルフィーがついたのかということについて、ちょっとお考えをしていただけますでしょうか。
Thank you very much, Watanuki-san. So we have a question from the floor on share source. So this time, as Morimoto sensei said, the clinical benefit is not clear yet, but even then, this new technical fee addition was realized. So are you surprised, or what is your take? What is your view on it? And another related point, the evidence is twofold: resource consumption and QOL. And this time, MHLW did the technical fee addition. Were they looking at both two equally, or were they weighted to one over the other? And why, as while this the evidence is not benefit is not clear yet, it still led to realization of this new technical fee addition?
森本先生、すみません。はい、
Sorry.
はい。
Yes, please.
Sorry、すいませんでした。そうですね。基本的な考えとしては、私からも先ほど申し上げた通りなんですが、そうですね。何を見てるか。どうなんでしょう。その中医協で実際どういう議論がされ方っていうところに関しては、こちらには細かい情報が入ってこないので、我々の出したエビデンスも少しは役に立ったというようなことは聞いておるんですけれども、具体的に何を見たかっていうところはちょっとはっきりしない、我々としてはちょっとつかめずにいる。そういう意味で我々もちょっと驚いているっていうところではあります。むしろここは綿貫さんとかあるいは関口さんにご意見を伺いたいところです。
So I talked about the basic thinking earlier. So what they are thinking, I do not know. I do not get the details on the discussion by CSIMC, Central Social Insurance Medical Council. And but I heard that the evidence that we submitted were useful. So we do not have a clear grasp on what they were looking at. So in that sense, I was a bit surprised. I think Watanuki-san or Sekiguchi-san can give us more insight.
はい、ありがとうございます。関口さん、じゃあ、今の件、ご意見があればお願いします。
ありがとうございます。通訳どうぞ。
Yes, Sekiguchi-san, if you could share with us your view. すみません。
ありがとうございます。再びになりますが、バクスターの関口です。今の問題につきまして、私ももちろんあんまり詳しいあそこの中共の議論の中の詳しいところにはよく把握しきれてはいないんですけれども、中医協では透析医療に関する 今回の診療報酬の改定というのがいくつかなされてまして、今回のこともですね、いわゆる腎代替療法の、診療報酬の重点項目として、扱われている中の、一環であったということも、一つの流れなんじゃないかと思います。そういう先ほどありました、特にQOL を改善するっていうところについて、在宅の腹膜透析医療全体が中医協の中で評価されて、今回の加算につながったということもあるかと思います。先ほど私が保険償還の累計の中でちょっと述べたんですけれども、会社から申請を出す場合、学会から申請を出す場合、それとあと中医協が重点項目として取り上げる場合と3つあるかと思うんですけれども、今回のこの件に関しては企業ということでもなく、学会が当初は申請していたんですけれども、最終的には中医協の重点項目ということになったと認識しています。
Thank you very much. So this is Sekiguchi from Baxter, and I do not fully understand the detailed discussion in CSIMC either, but regarding this dialysis therapy, there are a few reimbursement revisions, and this time it was one of the ones that were handled as the important item of the RTT, the renal replacement therapy. And so I think this is one trend, one flow. And I talked about the enhancement of the QOL earlier. So the home-based PD as a whole, I think, was evaluated by CSIMC and led to this addition, I think. And earlier I talked about the total reimbursement. There are three. One is from the company, application from company, and then from the academic society, and a third as the important item as CSIMC, and this time it was not the company. Initially the academic society applied, but in the end it was the CSIMC important key item.
関口さん、ありがとうございました。さらに今、フロアから質問がありまして、ロングタームのベネフィットが明らかになっていない中で、どうやってこの新しい技術量がついたのか、ということについて質問ですが、それは今、関口さんのお答えからすると、やっぱりもちろんこのいろんなデータを森本先生のところでデータを取られたのもありますが、それに加えて、腹膜透析というものに対するプライオリティが医療政策上高かったというのは貢献していると思われるというようなことでよろしいでしょうか。
So another question, follow-up question from the floor. So while the long-term benefit is not clear, how was this new technical fee added? And from what Sekiguchi-san just said, you mentioned that Dr. Morimoto gathered various data. And in addition, this PD priority was high in the medical healthcare policy. And so that was a contributor.
関口さん、いかがですか。
関口さん、please.
はい。私もそのようなことだと認識しています。
I have the same understanding. I agree.
ありがとうございました。さらにフロアから質問が来てまして、森本先生、関口さんに質問ということですが、技術量で評価する上では、明快、学会それぞれの役割があると思いますと。で、シェアソースについて行政がどのようなものを求め、それにどのように対応されたか、お話しできる範囲でご教示くださいということで、さらにそのサム D に特徴的なことがありましたら、合わせてご教示くださいということです。
Thank you very much. Another question to Sekiguchi-san and Dr. Sekiguchi, Dr. Morimoto. So in the technical fee evaluation, there is a role to be played by the academic society. Now, if you, as much as you can share, what is the government requesting in share source, and what steps did you take to address that? And if you could also share with us some characteristics of SAMD.
じゃあ、森本先生から。はい。
お願いします。そうですね。今回の評価については、ちょっと何ともっていうところが繰り返しになりますが、あるわけなんですけれども、うん、学会としても、あんまり、先ほど関口さんもおっしゃられた通り、学会を通したわけでもないっていうところもあるので、そうですね。実際にサービスを使っている医療者側として見ていると、基本はPD を、透析患者さんが高齢化していく、あとは QOL 重視っていう中で、その PD をしていくっていう中での、一つ一環として認められたのかなっていうところで、そこに関して、そうですね、アウトカムとしてもそういう、とりあえず短期の観察で QOL とかそういったところが評価されたというふうに、考えておりますという、推測にとどまりますけれども。はい。
Thank you very much. So the evaluation this time, I cannot be very clear again, but and as Sekiguchi-san said, it did not go through the academic society. And so from a healthcare provider that provides and uses the service, from our perspective, as the PD, the patients are becoming old and the QOL is important for them. And therefore, I think one possibility is that it was acknowledged, recognized as part of this PD, given this background, and also the QOL from the short-term observation, the outcome was evaluated. So this is my guess.
ありがとうございました。関口さん、いかがでしょうか。
はい。今の森本先生のコメントに付け加えて言うとすると、おそらくこの分野でのその遠隔モニタリングというのが、もしかしたら従来非常に特殊な、セラピーというふうに考えられてたのかもしれないんですけれども、今回やっぱりこうやって診療報酬の中に加えられていくという流れの中には、この療法が、いわゆるその標準的な療法だというような認識を、政府の側もして、それで、診療報酬に加えられるに至ったというような面があると思います。
Thank you. This is Sekiguchi speaking. So in addition to what Dr. Morimoto said, this area, the remote monitoring used to be thought as a specific, unique therapy. However, this time, this trend of having this added to the reimbursement, I think now government is starting to realize that this remote monitoring therapy is becoming a standard, and I think that led to addition to the reimbursement.
ありがとうございました。ちょっとまたフロアからもいろいろ質問が来ていて、少しこの、シェアソースからもう少し広い議論、デジタル全般の議論をしたいと思います。
Thank you very much. We're receiving more questions from the floor. So let me expand from specific share source question to a more digital as a whole, a broader area.
綿貫さんにお伺いをしたいんですが、今回、中医協で、この1年ぐらいですか、1年ぐらい、そのデジタルヘルスの保険について議論をしてきました。
Question to Watanuki-san. In CSIMC, for 1 year now, the discussion has been ongoing on the digital health insurance.
そこで、いろんな議論したんですけど、コアとなる、キーとなる結論は、SAMD であれ、普通の医療機器も同じなんですけど、患者さんへの有効性、安全性が高まることについては、評価をすると。しかし、医療者の利便性が、医療者への負担が減るとか、患者さんの利便性が高まるということについては、あまり評価をしないと。加算では評価しないというような流れが明確になったと思います。
So various discussions took place, and the key conclusion is for SAMD and for other normal, ordinary medical devices, the effectiveness and the safety of the technology for patients are evaluated. Higher safety and effectiveness is evaluated, but the alleviation, the lessening of the reduction of the burden on healthcare providers and the improvement of convenience for patients will not be positively evaluated. This became clear.
まあ、こういう前提で、こういう議論の下で今回の、シェアソースというか、まあ、腹膜透析の遠隔モニタリングの評価については、綿貫さんはどのようにお考えになりますでしょうか。
So on this basis, based on this discussion, what do you think, Watanuki-san, on this edition of ShareSource and PD, remote patient monitoring?
はい、ありがとうございます。今の田村さんのご質問に関しまして、今回のケースは厚生労働省の方針とある程度揃っていると乗っ取っているというふうに感じています。
Thank you, Tamura-san, for the question. So we think this time it follows or is in alignment with MHLW policy.
はい、今回は患者さんのベネフィットというのは森本先生がご説明いただいたように QOL の向上と一定のものはあろうかというふうに考えています。
So this time, as Dr. Morimoto said, there is a certain level of patient benefit as mentioned by the enhancement of QOL.
その観点から何らかの加算という考え方もあろうかとは思いますが、既存の患者さん管理という存在する技術量、マネジメントがあるということで、それにのっとった評価ということで、今回のお話になっているんだろうというふうに考えています。
So from that point of view, some kind of addition is thinkable, is possible, but given the current existing patient management, there's technical and management fee, and so we think this evaluation is in line with that, is based, follows that.
今回のこの技術を用いたとしても、これは森本先生からのご意見いただきたいんですが、患者さんの負担というのは、つまり例えば通院の負担とかは大きく軽減しないというふうには考えています。
So even by using this technology, I want to hear more from Dr. Morimoto, but even by using this technology, it will not reduce the patient burden, like the reduction in visiting the hospital, for example.
ですので、患者さんのベネフィットもそれほど向上しない。で、先生方の手番もそれほど変わらないということもありますので、これは技術量で追加的な評価なく、モニタリングが可能であるという従来の制度というか、そのモニタリングということに対して同等の評価をしたというふうに考えております。
And so the patient benefit is not higher, and the physician's burden remains unchanged, and therefore, for the technical part, this monitoring is possible without additional evaluation. That's why I think this was equally evaluated.
ただしかしながらこの技術は少し外れますが、医師もしくは患者様のベネフィットというものがある場合においては何らかの評価をしていただきたいというのは、企業側からしてみても一定程度希望するところになります。ですので、今後そのような議論というのはしていきたいというふうに考えています。
However, this digresses from the technical topic, but if the physicians or the patients, if there's a benefit on patients or physicians, we want that to be evaluated. The company wants that to be evaluated. So I hope this kind of discussion will take place in the future.
以上となります。
Thank you very much. That's all for me.
ありがとうございます。森本先生、いかがでしょうか。
Dr. Morimoto, please.
ありがとうございます。そうですね。実際にそのシェアソースを使っているものからの意見と、あるいはその観測と希望という点から申し上げると、今回これでシェアソースが使えるようになったことのベネフィットとして、ちょっとあまりパワフルでない ことしか今のところ出てないんですが、その一方で、例えば受診感覚とか、よりなんというか、患者さんにとって分かりやすい、QOL とか生活スタイルに影響するものに関しても、実際、プレゼンテーションの中で、PD の患者さんは月1回受診しますっていうことを書いたんですが、この月1回受診っていうのは、実はPD そのものではなくて、一般的には、腎性貧血、リーナルアネミアに対する注射薬の投与間隔の必要性から月1回となっていることがほとんどなんですね。で、ここに関してはちょうどタイミングよく2年前からですね、新しい内服の、造血剤が登場しまして、でそれによってうまくこれを組み合わせて使えば、例えば月1回受診する必要は投薬的にも大丈夫と。で、加えて、例えばシェアソースを使って家での治療データが得られて、それをもとに処方の、オプティマイゼーションができるんであれば、もっと受診間隔を広げられるとか、それによって、例えば、COVID-19 が流行っている中でも受診抑制しつつも安全で適切な治療ができるとか、そういった形でのアウトカムにつなげることができるんじゃないかと、実際使ってみては思っています。ここまで訳をお願いします。
はい。As the actual share source user, let me share with you my view as well as some observation and some preference hopes. The share source, the benefit is not so powerful at this current moment, but it will contribute to extending the visit interval and help more understandable, easy, clear QOL and the lifestyle promotion. And therefore, I mentioned that PD patients need to see a doctor once a month, but this is not for PD purpose. It's for renal anemia injection. And that's why it has to be once a month. And from 2 years ago, there has been this new oral drug which reduces the need for this drug to be given to the patient once a month. And so if this share source can get more data, the doctors can get more data with share source and also extend the interval of the doctor visit by using this treatment in an optimal fashion, then even under COVID, you can reduce the visit and still offer the safe, effective treatment. And this will be the kind of outcome that I am hoping to see in the future.
ありがとうございます。で、あともう一つ、シェアソースを使って医療者同士で話をするときに必ず出るのが、結局、医療者から見ると、見れるデータ量が増えたと。これ、見ることができるということと、見なきゃいけないということの間に大きな差があって、で、このシェアソースのこの遠隔モニタリング加算が、見なきゃいけないっていうことを強く要求してくるものでは現時点ではないと認識しておるんですけれども、見なきゃいけないってなったときに結局我々としてはすごくデータが増えてしまう。で、そこに関して何かそれは頑張れば見れるわけなんですけれども、そこに関して何か近い将来、シェアソースの遠隔モニタリング加算ができて、その遠隔モニタリングを高い質で行うために、例えばデータを見ることに対するさらなる加算みたいなのとか、あるいはデータを見ることを具体的にサポートしてくれるようなサービスであるとか、それに対するインシュランスカベレッジであるとか、そういうことが出てくる流れになるとすごくいいんじゃないかなというところを考えております。
Now, using this share source, the healthcare providers are now having a discussion, and what always comes up is, from our healthcare providers' point of view, it means we can see more data, but there's a difference between the fact that we can see and we have to see the data. And if currently there's no request for us to have to see the share source, the remote patient monitoring addition data. There's no request that we have to see the data yet, but if it becomes a requirement, then we will need to see more data. And in that case, of course, we will work hard to see all the data. It's up to our effort, but in the near future, if the share source is now added, and in order to enhance the quality, if we can see see another addition to seeing the data, or the service that supports us to see the data. If we can see an insurance coverage in that area, it will be highly welcome.
堀本先生、ありがとうございました。最後に、時間もなくなってきたので、最後に一つだけフロアからもご質問がありましたので、議論したいので、渡辺さんにお願いしたいんですが、そのエコノミカル、経済的な要素、そのコストセービングであるとか、費用対効果がいいという技術についての評価は、どう考えればいいかという質問が来てますし、非常に重要なところだと思います。そこについてのお考えなりをお教えいただけますでしょうか。
Thank you very much, Dr. Morimoto. So I have another question from the floor to Dr. Watanuki. So it's about the economic factor. So evaluation on the cost reduction and the high cost of benefit. What do you think about this? It's also an important viewpoint.
はい、ありがとうございます。現状におきまして、費用、コストエフェクティブといいますか、費用が優れるという観点で、点数がついたりとか、技術が作成されたりということは、なかなか難しいのかなというふうに考えています。
Thank you very much for the question. At this current point, it is, I must say, it's difficult to have the points or the technology established from the point of view of cost effectiveness.
一方で、医療機器、医療技術におきましては、その製品が費用対効果に優れるというものは間違いなくありますし、そういったものの評価というのはしていただくというのはやはり希望するところでありますし、そういった議論は今後必要になってくろうというふうに考えております。
On the other hand, in medical devices, medical technology, there are products with high, excellent cost effectiveness. So I hope that this will be evaluated, and we think we need discussion on this point too, going forward.
そういった議論は業界としても今検討しておりますし、今後の大きな課題というかですね、論点の一つになろうというふうに考えております。以上です。
This is already being discussed in the industry, and I think it will be a key point, key challenge going forward. Thank you.
渡辺さん、ありがとうございました。今のところに一つ付け加えると、確かに業界としては渡辺さんの言った通りなんですが、厚生労働省とすると、厚生労働省あるいは医療保険財政が今後に貢献する技術に加算をつけた場合、加算をつけるとそれは患者さんの自己負担が上がるということにもなるので、なぜ将来の医療財政がいいことに対して患者さんは自分で自己負担しなきゃいけないのかっていうような、疑問が出てくることがあって、そこは厚生労働省にとってなかなか難しい議論なんだろうなという気がいたします。
Thank you very much. In the industry, yes, as exactly as Watanuki-san just said, but as MHLW, so this the Health Care Insurance Administration, this addition will be made to the technology that will contribute to the healthcare administration. But this means, in turn, it will be more burden on the patients. Patients will have to pay more. So there's a question on why patients have to pay more for what contributes to the healthcare administration. So I think this is a very difficult point that we need to continue addressing.
ありがとうございました。もう時間になりましたので、これで、終わりにしたいと思います。短時間で通訳の方もありがとうございました。非常に中身の濃い議論ができたんじゃないかと思います。どうもありがとうございました。
Thank you very much. Our time is unfortunately up, so we would like to close this short time that we had. And thank you very much. I think we had a very substantial discussion.
ダニーさん、よろしくお願いします。
Danny-san, over to you.
Thank you, Tamada-san. And in closing, for everyone here today, I want to thank the APACMed teams, AMDD, and everyone for all the participation, Professor Morimoto and you and your group for all of this. It's clearly a clear topic for us. For everyone, so you know, I am the GM in Japan for Japan, so that I'm also on the executive committee of the AMDD. So with that being known, I think there's three main points for me that hopefully everyone understands we could walk away with today. The first is digital health and where it leads into reimbursements, the evaluations, everything. It's a difficult way to say it, but maybe it's vague or it's really not clear yet. But the importance, I think, is being called out today for everyone. And you could see from the interest, we know it makes a big difference. And there is no moving away from digitization and what's going to happen in the world related to health care and management and patient care, as we see in every other area of business and society. So I think it's happening. We need to be aware of that and participate in that, in the evolution. When I think about the next level, obviously we heard today, we talk about benefits. There were many questions from the audience, very valid, that we could touch on, not everything, but on why and the wheres and whats of reimbursement or the activities. And it's clear that it needs to be based on the benefit for the patient. I mean, that's why we're in this industry, and that's our ultimate goal, to improve patient care. But patient care is beyond, it's now getting so big. And I think we've all realized it, and Digitize is bringing that, is that to give continuous sustainable patient care, it needs to be economically efficient. It needs to be proficient for the physicians, for the staff. So part of the reimbursement policies, and I personally, I would compliment the MHLW in Japan for what they've done, in the fact that there's a lot of debate, but on one side, it's clear for the patients that this is happening, there's benefit. For example, Dr. Morimoto-san's presentation, but there's also efficiency benefits, and that needs to be part of our discussion. It's unfortunately, healthcare needs to be supported by the economics that are required. So let's not forget that. Let's take a balance in where we go, would be my other comment. And last is the RPM today in the discussion, remote patient monitoring. That's one point of digitization. It's a great example of what's happening and working. And, with that, we saw, I think we heard CPAP, we heard everything else, but a lot of that is on efficiencies. If you look at the histories of what's happening and you look at what it is today, most important for us is the future. And from industry, it's clearly the future. We're not looking backwards, we're looking forwards. And we're trying to help the patients because they will only grow. The need will become bigger, unfortunately, but that's why we're here. So let's think forward. I would encourage everybody to participate. Now is the time. Don't wait. Now is the time for us to help set the future. Now is the time for us to debate on what is the best for us all as society. So this is maybe not the start. It's been ongoing for years. But today, for me, for everyone to get together in this discussion is great, and I appreciate it. And I think generally, I'm kind of saying what everyone's thinking, I hope. And I hope together as industry, in collaboration with the physicians, in support of our patients, that this is what we're doing, right? So thank you very much today. Again, for all of the people involved and for the audience. This is not Japan, this is APAC. It's not APAC, it's the world. So let's participate, let's do what's best. And for today, let's hope our patients benefit. Let's hope everybody has a wonderful day and a week, or whatever it is in your lifestyle, wherever you're calling from today. It's a healthy work-life balance is what we're all after. So thank you very much and greatly appreciate it.